Hello and welcome to another episode of the Keto Answers podcast. I'm your host, Dr. Anthony Gustin, and this week we have a double whammy. We have two guests joining us. One is Rachel Gregory, who is a researcher based out of Florida, now living in San Diego, who has done a lot of research about a ketogenic diet, and Dr. Brian Lenzkes, who is a family physician down in San Diego, who lost tons of weight and changed his lifestyle after finding a ketogenic diet. Today we chat about if a CrossFit workout regimen and a ketogenic diet can exist together, the top lab you should ask for at your family physician, and how a team of Dr. Lenzkes and Rachel have been getting patients off medications with a ketogenic diet. Tons of information in this episode, so I hope you enjoy. Before we get to the episode, I wanted to chat about our sponsor, Perfect Keto. Perfect Keto is all about making a ketogenic diet healthy and accessible. Whether you're reading all of our online guides or articles or enjoying Perfect Keto's exogenous ketones or any other keto-friendly products, everything you need to make keto work for you is at perfectketo.com. I know what you're thinking. Hey, aren't you the founder of Perfect Keto? Yep, that's right. And all of my insanely high standards have been put into making each and every product. My background as a functional medicine clinician helps me craft the cleanest and healthiest possible products and best information about a ketogenic diet. Head on over to perfectketo.com to learn anything you need to know about the ketogenic diet. And if you've never tried any of our products before, feel free to use the code KETOPODCAST for 20% off your first order. With that being said, let's get into the show. All right, Rachel and Dr. Lenzkes, how are you guys doing today?
Pretty good. How are you?
Doing great. Thanks for having us on.
Oh, of course. So I think before we get started, you guys both have very different backgrounds. Rachel, why don't we just chat briefly about kind of where you're at and how you got started with a ketogenic diet and what you're focusing on now?
Yeah, sure. So I came across the ketogenic diet in grad school when I was looking for a topic to do my master's thesis on. And so I ended up doing a study using the ketogenic diet in non-elite CrossFit athletes. And it was pretty successful. And I ended up showing my research at the National Strength and Conditioning Association conference.
So I'm gonna pause right there and say that I think that you're still one of the only published papers on high intensity in CrossFit and ketogenic diet. Is that right?
Actually, as of 2 weeks ago now, Ryan Lowry and Jacob Wilson actually came out with another one.
Okay. What findings did you have in that, and what was your initial interest in that topic?
So I was just looking for a nutritional intervention in an exercise group. Like that's what we needed to do for our thesis. So I came across keto. I came across Jimmy Moore's book, Keto Clarity, and read it in like a day, and was just kind of super impressed with everything that was in it. And so just decided to use that as my nutritional intervention. We had a 6-week study. There was about 30 total participants, and we split them up into two groups, a keto group and just a standard American diet group. And the results were pretty great. After 6 weeks, the keto group was able to drop a good amount of body fat and fat mass, while still maintaining their lean body mass and also increasing their performance to the same degree that the control group was.
Yeah, that's fantastic. And do you know what the data was from Ryan and Jacob's recent paper?
Yeah, so they had, their study was a little bit longer, it was 12 weeks, but they only had, I think it was 9 it was a small group of people. I think it was like 9. But they kind of had the similar results. They did blood work, which we weren't able to do blood work because we didn't have the funding. But they did some blood work, and they had good results as well. I looked at the paper like 2 weeks ago, but it was body fat loss, fat mass, similar parameters.
Yeah, that's one of the questions that I get very frequently is, can I still do high intensity workouts and CrossFit specifically with a ketogenic diet? My answer is always, if you're a competitor, it's probably not a good idea. But if you ratchet it back and listen to your body, that usually you can have a little bit of both. But yeah, so yeah. Sorry, I just wanted to address that. It's just a very, very common question that I get asked very often.
Sorry.
Go ahead.
No, I was just gonna say, yeah, it's super individualized, and it really depends, like if you are an elite athlete or if you're just an average Joe who goes to CrossFit just to get a workout in. There's a whole spectrum, and it just depends.
Yeah, and I think we can dive in deep about CrossFit here, but a lot of average Joes act like they're competitors, and so I think that's where there gets to be some confusion as well. So you presented the research findings, and then this kind of led you down a path of digging more into ketogenic diet and how it works for people.
Yeah, exactly. Yeah, it just kind of became my passion. I found myself waking up every morning just wanting to learn more and do more research. I got into a job as a nutrition scientist for a supplement company. And I just wasn't, it was more formulation and kind of stuff like that. And it wasn't super interesting for me. It wasn't something that I woke up every morning and was like, oh, like I want to do this. So I basically just kind of quit my job and moved to San Diego last October now. It was, I guess, 4 or 5 months ago. And decided to just find keto full time, kind of got my own business going, and started doing some other collaborations and stuff like that. And now I'm here with Dr. Lenzkes and trying to, help people out.
Love it. And Doc, what's your background with the ketogenic diet?
Well, I've struggled with weight my whole life. And so as I started getting older, it didn't get any easier. In med school, we're trained to eat whenever we can and shove down food because we don't know when we're going to eat again. And residency gets worse because you're really busy. And so you stop taking care of yourself as well. And I've always worked out, 5 or 6 days a week, but every year, 5 pounds, 10 pounds kept creeping on. And so I started looking at different options and I went on a medical trip to Guatemala in January of 2017. And when I got back, I was the heaviest I ever was. And I was drinking green drinks every day. And, you throw a bunch of vegetables in there, but you throw in fruit juice to make it taste good. And then you're eating small meals throughout the day to keep the furnace going because you're told you're going to shut down your metabolism, that you have to eat breakfast, you have to eat 6 times a day, small meals. And it wasn't working. And I saw that for my patients, it wasn't working. So I took the step after watching Jason Fung on YouTube and talking about insulin resistance. And once I understood that concept, it really set me on my way to the ketogenic diet. I did paleo and things like that before without much success because I was profoundly insulin resistant. So once we started understanding that concept and cutting down on foods that spike the insulin, we just do a lot better. So I started using that in my diabetic and pre-diabetic patients with outstanding results. And so we kind of just kept going down that path. I went to the Low Carb USA conference that was here in San Diego, and it was outstanding. And I learned that there were a lot of other medical conditions that were responding to this kind of diet.
Love it. And so when you first looked at Dr. Fung's insulin resistance, his content on that, what was it that you learned that was kind of an aha moment that you started applying to both yourself and your patients? If you were to break that down for somebody who's never heard of that term before.
Yeah, I think that video really, when I first watched it, I thought, oh, this guy's going to be selling something. He's a typical doc that's out there. He's got some kind of angle that the rest of us don't have. And as I watched him, I thought, oh, this makes sense. Because when he talked about insulin resistance and starting to understand why we're seeing such a disaster with our diabetic patients, it starts to make sense. So the analogy that he used that I really liked was that when we see our diabetic patients come in, we see the high sugar and we react to that and say, okay, we're going to put you on insulin because we know that lowers sugar down. So common sense wise, that makes sense that we should lower the sugars with a drug or with some kind of medication. But what wasn't clear and what isn't clear to most doctors is that most type 2 diabetics have really high insulin levels. So in the setting of a high insulin level, they become resistant to the insulin that's there. So it's basically not doing the job. The analogy that he used that made a lot of sense to me was if an alcoholic came in and said they're drinking 10 beers a night, but they can't get drunk, what should they do? It would be crazy for us to say, oh, if 10 beers isn't working, go to 12, 14, 16, 20 beers until you get the effect, rather than saying, hey, let's cut down your alcohol for a couple of weeks and then go out with your friends and it'll cost you a lot less to get drunk and you're only going to have 1 or 2 drinks. It's the same idea with insulin resistance. The more we make our body sensitive to insulin, the less we need floating around. And as docs know that when we put someone on insulin, they're going to gain 10 or 20 pounds. And when they do that, we get frustrated with them and say, oh, look, you're not following what we told you to do, which was the standard diet, which wasn't working in the first place. And then they gain 10 more pounds because we've made them more insulin resistant. So what we're doing is making the problem worse by our treatment.
Right. And so if somebody who had no idea what you're talking about, they understand, okay, you want less of that if you're insulin resistant. What is the cause of insulin spiking up and how do people control that?
Well, the main thing is carbohydrate intake. Now, there's a ton of factors. That's what Rachel and I have been working on. is stress reduction, getting enough sleep. There are studies that show that if you're chronically sleep deprived, like many of us are, insulin bounces up. So it's not all diet. When we talk about the Mediterranean diet, those guys, they have a different outlook on life in that area. They look out and it's kind of windy that day, so they decide not to go fishing. They're just going to hang out and talk to their friends that day. They're not in a high stress job with their boss yelling at them, tense, trying to pay their bills and frustrated all the time and not sleeping. So their lifestyle is the big key. It's not so much their diet, because they eat a high-fat diet with vegetables and a lot of meat. But they also eat a small amount of pasta, but it's minimal. That's just like a side dish to them. It's not like the huge plate that we're eating here. So there's a lot of factors, but the big thing is this. If you go out and have a Slurpee for breakfast, say, or the standard American diet, we'll just say that we don't have to be that radical. We'll just say you have orange juice and milk and cereal, right, and a piece of toast maybe with jam on it. What you do is you spike your sugar right away. And the natural response of our body is to spike insulin to get rid of that sugar. So now we're eating 6 or 7 times a day. And every time we're doing that, we're spiking our insulin. So our body has a natural tendency after time, if there's a constant signal being fired, to ignore it. So you need more and more of the stimulus, right, to get the response with it bringing the sugars down. So in effect, what's happening is when we check that fasting insulin, when it's really high, that's your insulin before you eat anything.
Right.
So it's just sitting around at a high level. And insulin is the number one determiner of fat storage. So when you have a super high insulin level as a baseline, when you eat something, it's going to spike way above that. So we're just basically putting ourselves into a fat storage mode, because our body can either burn sugar or it can burn fat. So what the ketogenic diet is talking about is making fat its fuel source rather than depending on sugar, because you can't metabolize both at the same time.
Right. And I think this obviously differs per individual, but the population you're talking about is probably like not the CrossFitter that Rachel was studying before. And so when people say like, oh, well, do you think carbs are terrible? I mean, my opinion is that absolutely not. I think that certain people can use them for certain reasons. But if you're having somebody with diabetes or obesity that they're trying to treat, like you said, you eat sugar and insulin, it rises to basically clear it out of the bloodstream. It can go a couple different places, to be very simple about it, but either stored as liver glycogen or muscle glycogen. And if those stores are topped off, then insulin shoves the glucose into fat cells. And so if like you said, insulin's always high, whatever you eat is going to be shoved into fat cells because you're never tapping into that liver or muscle glycogen. Is this correct as far as how you explain it?
Absolutely true. And I think that's the big thing that all of us here in San Diego that we're talking about this stuff, coming from different modalities, nutritionists, chiropractors and docs. Those of us who understand the concept, we understand it's a spectrum. It's not a one size fits all diet. And that's what we've been doing. When you have a food pyramid that says, okay, we all eat the same thing, we know we're all not going to respond that way. So about 1/3 of people are insulin sensitive, meaning they could eat exactly what you're saying. They could eat more carbs, they could have fruit juice, they could do this kind of stuff, and they're not going to run into trouble for a long time. But they could put themselves into where the other 2/3 of people are of being insulin resistant. So when you're insulin resistant, now everything changes. It's kind of like instead of having to get a oil change, now you need a major tune-up. So my guy, as a matter of fact, I have a guy who's lost 130 pounds. He came to me at 465 pounds. So when we talked, I said, look, you got to cut out fruit, orange juice, all that stuff in order to make yourself insulin sensitive, because his insulin level fasting was over 40. So it should be 5 or less. So when you're over 40, first of all, you can't fast. You're going to get stressed out. And a lot of people feel that way. They have to eat every 2 or 3 hours because they're running on sugar. And when they don't have an energy source, those high insulin levels block us from getting to the fat stores, right? So that being said, one of the interesting things that we're finding is that there are athletes who are thin and they're in pretty good shape, obviously, but they still have to spike their insulin to get rid of the carbs that are in the bloodstream, because our body sees carbs as a toxin, which they are. People with poorly controlled diabetes have blindness and kidney failure and a lot of neuropathy and things along those lines. So one of my guys weighs 157 pounds. I diagnosed with type 2 diabetes, who leads expeditions across the Grand Canyon. So looking at this thin guy, I said, there's no way. The lab had to have made a mistake. It's impossible. But the point was, he just burned out his pancreas. His his beta cells in his pancreas couldn't keep up with the insulin demands that his body was putting it under, even though he wasn't storing it as fat. He was burning off the calories, but it still had to get out of the bloodstream to either, like you said, either put it to the glycogen storage in the muscles or, store as fat around the liver. So the point is, some of us are being fooled, and I think that's why we're having a big push to say, hey, look, let's get a fasting insulin level and see where you're at, what degree of insulin resistance you have. So a guy like you who's really fit, yeah, sure, you can get away with a lot more carbs than someone like me who's more overweight and insulin resistant. So it's looking at the spectrum, and I think that's where people like Rachel and some of the nutritionists I work with in town here, Tri-System Nutrition, Jeff Cotterman, he gets the concept, but he had to switch over because he was convinced you had to carb load everyone. So you have a 300-pound guy, you really can't carb load that person. If you have a 150-pound guy who wants to be the fastest runner, he could probably carb load a lot better as long as he's not insulin resistant.
Right. One of the most interesting things that I get from people when I mention the strategy of eating to solve certain problems is, well, why doesn't my doctor know about this or tell me about it? And you said that you had to kind of relearn a lot of things from what you learned in medical school and what you were learning and utilizing in practice. What did you learn in medical school that was kind of conflicting with this? And what are some of the things that you think should be changed maybe in a curriculum? And I mean, don't get me started on how curriculum in grad schools are made, but I mean, this is one of the things, like everybody assumes that people, when they're experts, either, physicians of whatever kind, nutritionists, that they should always know what is best. So I'm just kind of curious as far as what you learned and what you had to replace as different models of thinking.
Well, a lot of people don't realize in medical school, we get hardly any nutritional training. All they do is say, hey, supplement your vitamins if you need it. And fat's bad for you. That's the extent of it, pretty much, right? Don't eat fat, you're going to clog the arteries. And so when you start looking back and you say, well, if all these guys are on a low-fat diet, why are we getting more heart disease, more obesity, more diabetes? If that's the problem, and when you look at what Americans have done, they've actually listened to some degree to what the recommendations were, but they're getting worse. It's kind of like if I tell you how to golf and you're doing it the wrong way and you keep practicing all the time and you're not getting better. So I think when we step back and look and say, gosh, the recommendations we're giving people to eat 6 times a day, they're not working and people aren't getting better. If we see everyone better, then, it's funny because a lot of people say, oh, all these fad diets keep coming out. And the reason they are is because the standard diet is not working. So if I have a medicine that works for, heart disease, for instance, or hypertension, and it works great, that's going to be the only drug on the market. There's a reason we have multiple different drugs on the market because one's not doing the job. So I think part of it is we just blindly believe what our predecessors have told us. The older docs said, hey, look, fat's bad, stay away from it, eat eat a low fat, high carb diet. And it just, when you step back and think about it, it doesn't make sense, especially for a diabetic, because sugar's their problem and you're giving them more sugar and you're cutting their fat, because the idea is this: the diabetes educators believe you got fat and then you got diabetes because you're fat. And that's not necessarily true. Like I was saying, I have at least 7 guys in my practice and one female who's diabetic that are thin. They're below the standard weight and they have type 2 diabetes still, but they all have a high carb diet. So I think what you have to do is step back and look at the data. And that's what I had to do. I just step back and say, okay, can it be true that eating a higher fat diet isn't going to kill you and cause heart disease? And I don't know if you've come across Dr. Kraft and his work and Ivor Cummins. There's some data that's really incredible that goes against what we've been taught. And I think when you have an open mind, you start having to look at the big picture and say, can this be true? And the main point that Dr. Kraft was making was that insulin is the problem. This guy he was a pathologist and did autopsies for over 40 years, maybe 50 years. And at the end of his career, when he was 86 years old, he stepped back and reviewed the data, thinking that LDL was going to be associated with all this stuff. And what he was seeing was that insulin was the main thing that correlated with strokes, heart attacks, and peripheral vascular disease, not the LDL. It wasn't even a factor when he looked at it. So it was shocking to him. And so basically his conclusion was that these people who had these events either had diabetes, pre-diabetes, or their doctor didn't make the diagnosis. Right. And when he looked at their insulin levels, they had really high insulin. And so when I heard that, I went back to my practice and thought, I'm going to take a look at my patients who've had a bypass or multiple stents. And every single one of them had a high insulin level. They weren't all diagnosed with diabetes. So that was a ground shaker for me, because I had to step back and say, okay, their LDLs are normal and they've had coronary disease. And if you look at some of the studies, 75% of people admitted with a heart attack have normal LDL and total cholesterol. But those same people are going to have low HDL, which is the good cholesterol, and high triglycerides. So there's a guy named Dave Feldman who's looking at this data, and he's made a lot of remarkable discoveries that have really shaken our foundation from a cholesterol standpoint.
Yeah, I mean, this is another thing with kind of the misinformation about nutrition and insulin as a whole. I mean, cholesterol and fat panels, and looking at that, and the fact that people don't look at inflammation with this. They don't look at how triglyceride and inflammation are paired. They don't look at, an NMR profile of what is the LDL. Is it a small dense? Is it a large fluffy type of LDL? Like you said, insulin levels, the labs as a whole, the person's lifestyle as a whole. There's so many more factors that go into it than just ordering a CBC and a standard lipid panel. That is really frustrating me. I get messages probably every single day on Instagram of people who are trying to get better, and they say, I switched to this diet. I'm feeling great. I lost a ton of weight. Inflammation markers are down, and everything else, but my LDL went up 10%, and my doctor's worried.
Yeah.
Oh, well, okay. Why? And this goes back to what you were saying is, does the research actually point to a pure LDL from a lipid panel sample, like a standard lipid panel result, to actually reducing the risk of any of these diseases? And like you're saying, there's a lot of contrary evidence, and especially when you pull in all the other data, that it's not really that important when you look at it as an isolated factor. I have a question about what type of practice you had before you started getting into all this stuff, and how has that shifted now that your mindset about approaching a patient has maybe shifted a little bit?
Well, I'm general internal medicine, so I deal with all disease processes. So basically, family medicine for adults, anyone over 18. My shift, I think in my old age, I'm starting to get more frustrated by the system. I think we go into medicine and we have our new white coats and we're going to save the world, and we realize we're not really saving the world. We're seeing people getting worse. And probably the biggest killer we see is diabetes. We're seeing, I've seen the devastation that happens when people are in severe pain because of neuropathy, which is burning pain in the feet because of high sugars for a long time, and probably insulin contributing to that, and blindness and kidney failure and dialysis. And Jason Fung was seeing the same stuff. And you think, man, what could we have done to prevent this from happening? What could we have done 10 years ago or 20 years ago? And I think as I'm getting older, I'm thinking, guys, if you're not willing to give up some of these things that are killing you, I can't go down with the ship. I see a lot of these guys because I can predict the future. I can see what's happening. If your sugars are running, 300, 400 all the time, and you're 35 years old, by the time you're 50, you're going to be an absolute disaster. It's just like running your check engine lights on and you're driving with no oil. You're going to blow up your engine. Any mechanic will tell you that. So they could tell if you don't start doing maintenance, you're going to blow up your engine. So the problem is there's a big push now with not prescribing pain meds and things like that for docs. But these people are in severe pain now. Now we have to treat the problem that we never treated before. We wait till it's a total disaster, and then we're the best in the world at fixing a major disaster. But we should prevent the accident in the first place, if that makes sense to you.
Yeah, absolutely. What about the time you spend with a patient before you started dealing with all this stuff now? Are you working with more people, say like Rachel, who do a lot more intense nutritional therapy with the patients, or how are you approaching this differently?
Yeah, my view has changed drastically, and Rachel will tell you that. My frustration is I don't have that much time with a patient, and it takes me a long time. So what I did is I spent tons of time with each patient that I really wanted to help. But I have my medical assistant knocking on the door saying, "Hey doc, there's people waiting. You got to get going." But you're trying to have a breakthrough to really help this person, instead of just saying, "Okay, you know what? Let's just throw 3 more drugs on. You're doing fine. Keep doing what you're doing." Right. So my dilemma was this: before going to the Low Carb USA conference, I was the only guy who really was doing this stuff in town, and no one got it. So I didn't really have a nutritionist to send people to. So I said, well, if they need help when they plateau and to understand, I can't be that person. My person to make the diagnosis and look and say, look, we got to start cutting your carbs. Here's what we have to do. Let's get you on that plan. But I can't manage weight loss and all that kind of stuff in my capacity as a doc, because I have people with colds and flus and all that kind of stuff to see, and I can't spend that much time per person. So what we needed was a network, and that's how I saw it. And so I reached out to a guy named Jeff Carterman, who I told you about with Tri-System Nutrition. And I said, Jeff, look, I like you as a person. I know your integrity, but carb loading these guys is not going to work. So I can't send my patients to you. But if you get one nutritionist there who gets this stuff, I'll send you everyone I have, because it's that important. And so going through the process, he converted over, and he's a super athlete, cut guy, and he ends up losing 20 pounds switching over to a high fat, low carb diet. And so that was a shocker for him, and his strength got better and he got better. And so now he's implementing that with his obese patients, and they're doing great. They're having results that he's never seen before. And so it's an exciting thing to see that, and just realizing we can't be fighting with the nutritionists. We got to get on the same page and do what works for the patient. And then by a miracle, Rachel moves a couple blocks from my office. And so, through friends, we connect, and she's doing amazing stuff with her 21-day challenge, getting people into keto to slowly learn. And I'll allow her to tell you about that more, but she's being able to help people and get them on the right path without totally overwhelming them. Right now we're doing a 6-week conference at a church that they were kind enough to let us use their facilities. And so we're taking people stepwise through this stuff. The first week was all medical stuff to tell them, look, you're not going to blow up your heart and die from, going into a ketogenic state, and that it's actually healthier for you, and you're going to have better focus, mood's going to get better, all those kind of things that we're seeing. And then going through and having Rachel show them practical application of this. How do I do this when I go to a restaurant? How do I cook at home? And what do I do for lunch? Things along those lines. And now we're getting into more of the question and answer and the nuts and bolts of this, how exercise and sleep and lifestyle all connects. So I think we're going to do a great job of really helping people to have healthier, longer lives, really get into the root cause of their problems. And I think the data's there, and we have enough scientists and researchers and people out there that are able to make a difference.
Yeah. And this is actually, when you said that, you were getting knocked on the door from your assistants saying that you had people waiting. I was doing the same exact thing, but 4 years ago when I was in full-time practice, where every time that I was going over on a patient visit was because I was talking about nutrition with the patient, because I knew that whether it was a sports injury or managing diabetes or obesity, it was always came back to nutrition. And so that was the point where I was like, okay, this needs to be solved in a more scalable way. And I can't be the one, just like you were saying, that takes people through every single step of this. It's just, you need to have a network of people, in my opinion, and have it be kind of a more tiered approach where, like you said, you segment and you do diagnosis. Someone like Rachel can take them through some of the struggles, which I would love to chat about. So if any of those things that you've learned, Rachel, that you'd love to talk about as far as the biggest sticking points in getting somebody over the threshold of, say, a standard American diet into eating like this, and then also maintaining that, I think are two big things where thresholds, once people get past, it's much easier to maintain the lifestyle. What have you seen working with the population down in San Diego?
Yeah, exactly. I mean, the main thing is that there's so much information out there, especially with, keto coming out now as kind of, this fad diet or this buzzword. There's so much different information. It's really hard for even, us to kind of sift through, okay, what is legit and what's not. And so that, just thinking about someone who's never even come across this subject before, and they're trying to get into it and they have no idea what to listen to. Like, they Google one thing and then, on the next page, it's the completely opposite. So what I've found is that just taking it back to the basics and really trying to, just like from what I found from working with people, trying to throw all of the information at them at once, it's just too overwhelming. Even if you've done keto before, even if, you think you've done it or you think that you're doing it, there's still so many different loopholes that you need to go through. And so just, working with people over the years and doing that kind of stuff, I just kind of came up with a system where I teach them something new every day. And it's, yes, you're going to have some people who are they know a little bit more about it, but I also point them in the direction to more resources if they are more experienced. But then you're going to have someone who doesn't really even know what the difference between a carb, a fat, and a protein is. So there's a whole spectrum, but from what I've seen, it just getting people, learning about it and understanding these things rather than just telling them to go out and do it. And that's what I found is a big issue too, is a lot of people, they just want you to tell them what to do. They want you to make a meal plan for them, tell them exactly what to eat. They don't really want to understand it, or they just, can't really understand it because it's a little bit too sciencey or complicated. So I think a lot of the, making this into a lifestyle is kind of being able to understand, what's happening, why you shouldn't be, eating every 2 hours, eating carbs in the morning, spiking your sugar, spiking your insulin, what is doing to your body, and why it's important to, address that now so that you can, make it into a lifestyle.
And what about maintenance of the actual diet? Let's say they get in a roll. A lot of people that reach out to us are very frustrated that, they get all pumped up, they see their ketone levels boost, and then they, eat a piece of pizza and they feel like they've failed and everything's ruined and they might as well not ever do it again. And so, or, they switch jobs, they move or they travel and they think that, completely worthless now. Any strategies for maintenance of a ketogenic diet that you've seen work really well with people?
Yeah, so I think one of the things is just with a lot of people with the blood ketone numbers and stuff like that. There's some people who are test all the time and then they start to see their numbers go down. They get frustrated with that. But I think the main thing is to really look at the overall picture and see how are you feeling throughout the day. What did you change? So if you are in maintenance mode, so a lot of people, they'll, go on a diet or go on the ketogenic diet. They won't really be exercising that much in the beginning. And then they start to feel better and they start to, have more energy. They're losing weight. They want to get out. They want to get active. So they start, increasing their exercise, but they're keeping, maybe their calories at the same, lower level that they were when they were trying to lose some weight. And then they start to feel like crap because they're expending more energy than they, were before. So one thing is just, making sure you're getting in the right nutrients and getting in the right calories for your body, and not necessarily saying, oh, you need to go, track everything you're eating on your MyFitnessPal, but kind of just becoming more intuitive with your body and understanding, okay, I'm hungry. Like, this is real hunger. I should eat now, just those type of things.
Yeah, that's an interesting point that I never really thought of, is that people, when they have more energy, are then expending more energy and probably need to eat more. One of the biggest things that I do see just from getting started in a kind of a flaw in most people's approach to a ketogenic diet is that they just undereat from the get-go. But I haven't really thought about this from the standpoint of having more energy, and then, especially if somebody's super sedentary or overweight and not really motivated, and then they start having more energy and actually getting out and doing things, that could increase their demands for energy. People think that, it's hard to bust all these myths at once. It's like you eat fat, or you don't have to eat every couple hours, and then also that you do need to eat a decent amount of food, and that less calories isn't more fat loss always. And this is another struggle that, and a good point that you made about that, and the ketogenic diet needing more energy kind of as you go along.
Yeah, exactly. And I think there's so many different, it is a very individualized approach. And that's, with my challenge, it's 3 weeks. So it's 3 weeks of giving you information, trying to weave through, some stuff that, might not be as true as you thought it was, or just kind of, teaching you a little bit more. And then after that, we have people, what we're trying to kind of build here is, putting people through the nuts and bolts, and then, after that, taking a more individualized approach. So once they kind of learn the basics, then you go in and say, okay, what's your individual, exercise routine like, or what's your sleep like? What's your daily stress like? And try to hit on those different points individually and see if there's different things that we can implement to help move you along in those areas. Cause that's generally where, the plateaus come. It's not just the diet. There's all the other factors that play into it.
Right. And so what are some of those other factors that you've noticed besides just nutrition, the kind of the big key movers?
Well, aside from, so some people are going into ketogenic diet. They don't have that much to lose and they're already very active. So maybe, for example, let's take, a CrossFit athlete or just a girl competing in CrossFit. She's not like super elite, but she wants to lose a little bit of extra body fat. One of the things is just, especially for women, starting, a ketogenic diet and decreasing their calories at the same time. So that's one of the things that I've seen is, going into it in a caloric deficit rather than going into it maybe even in a little bit of a caloric surplus, but, taking that surplus into a little bit more fat, obviously moderate protein, and focusing on keeping their carbs low. But then also, with the overtraining part of it. So, for example, in my mind, I think that every single person can benefit from being on a low carb diet because it's going to give your body the metabolic flexibility to, prosper in the long run. So even if you are an elite CrossFit athlete, if you can say, during the off season, after the CrossFit games are, beginning of August. So then you have, 5 months until the Open starts in February. So during that 5 months, maybe take your training down a little bit and see if you can get into a low carb keto, diet and see if you can get your body adapted in that period for that 5 months period. And then once competition time comes, you can use carbs strategically. And so you're better able to, one, recover after your workouts, especially in CrossFit. There's, multiple workouts a day, especially at the CrossFit Games. And a lot of people don't take that into consideration. They take into the consideration only the part of it that's like the glycolytic sport. Okay, I need carbs. But what about your recovery? What about your neural fatigue? We know that, ketones, the ketogenic diet has been shown to reduce inflammation and help with recovery. We know that it has neuronal aspect to it. So decreasing neural fatigue during that workout, that's a huge thing. And just being able to be metabolically flexible. So using those carbs to your advantage, saving those glycogen stores for when you need it. It's just, I just believe that every type of athlete could definitely benefit, maybe not being in a ketogenic state the whole time, but definitely using carbs strategically throughout.
Yeah,
So
that's a really good point about recovery, and then it's not just performance all the time. And so, if you're decreasing inflammation, if you're having better recovery times, then maybe you can get away with training more or actually having a better overall training volume without having to set PRs every single time and push it to the max every single time.
Exactly. Yeah.
So what are the things so obviously you're dealing with these different populations. What is the most common type of person that you're dealing with that could probably benefit? You said everybody can benefit from something like this. When you look at the standard, let's just say American population, to make it easy, like, what are the people that, if you were to say like this for sure is something you should try, what do those people look like and kind of how are they approaching their days? And if you could get anybody to switch to a ketogenic diet, who would it be?
Honestly, I would say that everybody, no matter who it is, should try it. At least just go through it, like, 3 weeks, just see. Obviously that's not enough time to get adapted and all that stuff, but you can kind of, 3 weeks of learning and we're all taught the guidelines, by the USDA. And that's another thing, just going back to what you were saying before about what we learn in school and in medical school. So when I was in, grad school, we were taught to go off of the USDA guidelines, which, 50 to 60% carbs, all that type of thing. And I had to go, even with my advisor, who is he's the head of the nutrition program, the master's and the undergrad at James Madison. He, had to kind of go against what he believed too when I was doing my research, and he had to go, dive further into the research. And I actually called him up last week to ask him, because I was just curious if I graduated a few years ago, if there had been any changes within the curriculum. And he said that I asked him, like, is there going to be any, with the new guidelines coming out, in 2020, are there going to be any major changes, or with all this research coming out? And he said that honestly, it's like 30 years out that these changes are going to be implemented, because there's just not enough research, or the research is being pushed under the rug from all of the politics and the money and the pharmaceutical companies and all of that that's playing into it. So it's very sad if you think about it. Like, just people who have master's degree in nutrition, like if you're just going to school and, basing your education off of the curriculum and not going outside the box and doing your own research, you're honestly probably not going to, have that much success.
Right. And this is a really good point, and why I almost lost it before when I was talking about curriculums, is that people think that at a organized education at an advanced degree gives you all the tools that you would need to have. And it's actually very backwards if you think about how that education system is set up and how curriculum gets made. And like you said, if you're not going out there and challenging your own assumptions constantly and learning, new stuff comes out all the time. And like you said, there could be a new study come out. Well, for that to get into a textbook, and then that textbook to influence people who are in school, is 10, 20, 30 years. And then once those people learn that thing, then let's say you go into a busy practice, whether you're a nutritionist or a personal trainer even, or a physician. Well, you do that for 30 years and you're practicing essentially with 60-year-old information, which is pretty insane.
Yeah.
So yeah, I mean, it's a good point that people should just do it to practice challenging their own assumptions and learning for themselves. It's a good point. Doc, any people or disease states that you found respond exceptionally well? I know you mentioned diabetes, but are you using it with any other, in conjunction with for therapy and any other conditions?
Well, I think my problem is I haven't found anything that it doesn't work for. I mean, I've been shocked. I sit back and think, wow, because I have two friends that I really talk to about ketogenic diet, and both of them have a lot of anxiety, stress, and both are doing outstanding, from a stress level. Their family looks at me like, what do you have them on? You must have them on some crazy med to get them this stable. So that's been a huge thing, because hormone shifts and fluxes and all that, just being under major stress and tension all the time is not good. I've seen hypertension improve. Weight, obviously, we always say that people have better blood pressure when they lose weight, but they're losing weight because they're getting their insulin sensitivity better. So a lot of the stuff we attribute to being obese, it's probably from the insulin resistance. Well, that's what I think we're going to ultimately find out. And so a lot of things that are surprising to me, that it's kind of the opposite of what I've always thought. For instance, triglycerides. I've seen people's triglycerides cut, 80% on a high-fat, low-carb diet.
Do you ever pair that with inflammation markers and see that they pretty much mirror each other?
Yeah, inflammatory markers come down, HDL goes up. And so when people get stressed out about their cholesterol going up, usually it's a transitory also. When you change your diet and you're losing weight, you're mobilizing the fat that's around your liver. So
Exactly.
Sometimes your cholesterol, no matter how you do it, in starvation, it will bump up cholesterol. As a matter of fact, Dave Feldman is a perfect example. This guy, his research was his cholesterol was always a little borderline. So he was going in for life insurance, and he's an engineer and an entrepreneur. And so he thought, I'll just fast for 3 days before my test, make my cholesterol look good, and get my best rates I can on life insurance. Well, he fasts for 3 days, goes in, and his LDL cholesterol is over 200. His LDL alone is over 200. Usually it's 130 or so. And so he thought, that's weird. The doctor called him in, said, you're going on meds today. You can't mess around. You're going to have a heart attack. This guy's an athlete. He's in good shape. He's not a big obese guy that you would think. So he got home and thought, I wonder how bad I can make my cholesterol before I start the med. So he went on a high-fat diet for 3 days, right? Just eating bacon and butter and all the stuff we're told not to eat. He goes back in. The doctor calls him and says, I think we messed up on that first test because your LDL is now like 120 or something like that. So he dropped it 90 points in 3 days. And so he thought, well, I'm going to fast 3 days again and see if that was a fluke. He fasts 3 days, it goes back up over 200 again. Then he eats for 3 days and it goes back down. So we look at that and think, wow, that's kind of a crazy thing to happen. It's exactly the opposite of what we would think based on our education. So he tried it with the rest of his family, and they all had the same results. So he's tried it with, I don't even know how many people now, and about 89% of the people correlate. So it's interesting.
So, I mean, the obvious deduction here is that when you are fasting or eating at a caloric deficit or using your own body fat as fuel, you're endogenously, or your body is producing more of these fatty acid transporters, which is cholesterol, and that number goes up. When you're eating a very, very high fat diet, maybe even to like a maintenance or excess mode, your body's using external sources of fat as fuel. Therefore, its endogenous production of this stuff goes down. I mean, obviously, if you have inflammation, it's going to jack up some of these levels because that's one of the things that cholesterol can do. But I mean, is this fair to say?
Yeah, it's complicated, and there's a lot of different factors at play. But what he's showing is it's a dynamic system. It doesn't mean your LDL is always 210. If it could change that much in 3 days with dietary changes, that tells us, do we need all these meds? That calls that into question, especially when you look at some of these drugs that were coming to market. There were a couple that would raise the HDL, the good cholesterol, like crazy, and drop the LDL like crazy. But they never came to market, not because of side effects. It's because they showed no benefit.
Right.
So if those numbers are that important, they should have had a huge survival benefit if those are the important factors. But what we're seeing is statin drugs work by decreasing inflammation in the coronary vessels, right? People have been talking about this for a long time, but it's never really got a lot of steam until now when we start saying, well, if we decrease our inflammatory markers through diet and lifestyle, does that put us at a much better risk than we can achieve with a statin drug? And I think the answer is yes. The New England Journal of Medicine just came out with an article saying that we can decrease our cardiovascular risk by 50% through lifestyle without meds. So as we know about the medical assistant knocking on the door, it's easier for us to say, you know what, your cholesterol's high here, take a med here, do this. I don't have time to talk to you about all the other stuff. Let's just get the numbers better so we feel better about ourselves and sleep better. But when you look at the data, it's not what we've been led to believe it is, as far as preventing heart attacks and strokes, especially in primary prevention, meaning someone hasn't had a heart attack before. The data is abysmal when you look at it. Right. So and even that's what's changed in my practice. Yeah, absolutely.
And even if the data showed that, let's say high LDL was correlated with these cardiovascular events, wouldn't the more appropriate question be, why is it elevated? I think that's something that we always brush over. And I think that your point as well about how transitory some of this stuff is, so we got free labs in grad school, and I tested one day in the morning and the evening, stayed fasted. My lipid panel looked completely different on the same day. And so let's say you're a little stressed, like somebody who has a poor lifestyle, and they go in and it's one day versus another, and that puts you over a certain range. And just because of that, once a year you get prescribed a medication. It's just insane to me. It's like not taking this variability in some of these labs. So that kind of brings me to a question of a two-part question. One, what labs are you typically running with people, and what are you seeing changed? And also, how are you using all of this to take people off of medications, or what medications are they able to stop taking now that they've gotten their nutrition and lifestyle under control?
Yeah, I think for me, the thing that's really changed, the biggest change in my career really is checking a fasting insulin level.
Okay.
Because, for instance, that guy I told you that was 465 pounds came to me. He hadn't had labs checked in 5 years, and he works for my wife, right? So I'm thinking, I shouldn't have helped it. I told him I'd help him for free. Come on in, I'll just help you lose weight, because I think a ketogenic diet's going to help you significantly. So he comes in, I get his labs, and to my shock, his 3-month sugar average is 5.2, right?
HbA1c.
Hemoglobin A1c, yeah. 5.2, which is stone cold in the bottom of the normal, right? His sugar's normal, liver tests are normal, cholesterol's better than mine. Everything's good on this guy. And I'm thinking, how in the world can this be? But then I get his insulin level, and it's over 40. This makes sense now. Just yesterday, I talked to a lady of mine. She's Asian. She weighs about 115 pounds. Her husband says she carb loads all the time. Her LDL cholesterol is in the normal range, but her HDL is super low, and her triglycerides are like 400, when what 150 is considered normal. So when you start seeing this, I said, you got to cut your carbs. There's no two ways about it. And her husband started laughing and said, see, I told you. She drinks orange juice. Everything she does is carbs. So she's at a much higher risk factor for heart disease than that big guy who weighed 465 pounds is. So what we're seeing is there's people that are at a higher cardiovascular risk than you would think they would be based on what they look like, right? So we're fooled by the external thinking that they're going to be fine. So when you look at the data, a thin diabetic, skinny arms and legs, big belly type person, they have a way higher risk factor than a morbidly obese diabetic, because the morbidly obese person is storing their fat in the periphery where we can see it. The one who's storing it around the organs is the one that's at huge risk of cardiovascular disease. This visceral fat is what we call it. That's why we look at stomach measurements and all that, around the abdomen. So that is probably the biggest change. I'll tell you, from my perspective, and Dr. Gerber, who's well versed in this area, started talking about coronary calcium scores. And so what you could do with this is a CAT scan to look at the coronary vessels. And that gives you a real-time determiner of their cardiovascular risk, way better correlation than what our laboratories are showing. The reason I bring this up is 4 out of 5 people in the last month that I've checked coronary calcium scores on, it's changed my management, because 2 of those guys had LDLs above 210, right? Their LDL's that high, and think, I'm going to put them on a statin, no doubt about it. But their HDL and triglycerides are excellent. They just happen to have high LDL. And when you look at their coronaries and their 0 score, their chance of having a coronary event in the next 15 years is close to 0. So those guys would have gone on statin drugs unnecessarily, especially when their cardiac inflammatory marker is normal. And I found that to be highly correlative of coronary disease, of having a high CRP, which is an inflammatory marker that we're looking at. So again, we start stepping back into this inflammation being the problem. So if your question is about which lab panels I look at, basically looking at a metabolic panel, like liver, kidneys, kidney function, those kind of things, because high liver tests, again, are associated with fatty liver. There's a test called GGT, which is more specific for fatty liver. And we're seeing, I think, at least now or in the next couple of years, fatty liver without alcohol, not alcoholic cirrhosis, is going to be the leading cause of cirrhosis, because we have a big problem with high fructose corn syrup and those kind of sweeteners that are going straight to the liver and causing damage. So my perfect panel would be getting a fasting insulin level, as we talked about, a 3-month sugar average, just to see where we're at metabolically. Lipid panel, and NMR, if it's covered by insurance, which is a more specific cholesterol panel. I think the big things we look at is the HDL ratio, HDL total cholesterol ratio. Really gives you a better indicator than what the LDL is alone for coronary risk factors. Triglycerides have become way more important in my eyes, because I see the HDL and the triglycerides being, it tells you what neighborhood you're in. Your LDL is going to fluctuate up and down, and I don't see that as much of a correlation as I do with people who have a high triglyceride and low HDL. They're at risk. There's no 2 ways around it. And Dave Feldman did a really good job of discussing this. He says HDL is kind of like the police in your neighborhood, because they're doing good stuff for repair. So when you walk outside and you see the police walking around your neighborhood, you can assume everything's okay because they're just doing their daily thing walking around. When you walk outside and all the police are gone, you know something bad's happening somewhere. So that's his analogy of that. So when your HDL starts dropping down and your triglycerides are going up because of high inflammation and damage, then you're at an increased risk of coronary disease. And what a lot of us are talking about now is the LDL in itself isn't a bad thing, but once it gets oxidized by its environment, then there's receptors that are taking that up and caused by foam cells and causing damage to the endothelium of the blood vessels. And that's what's causing the problem. So inflammation sets us up for that kind of neighborhood, basically.
Right. And one of the good things that you pointed out earlier, which in my opinion is a mark of a really excellent clinician, is that you said, I'm ordering this lab more, the coronary calcium one, because it changes my management of the problem. And so when people say that they do all these crazy labs, or people especially get into that kind of the biohacker-esque mentality of needing to run every single lab under the sun, the mentality of like, will this actually change what I'm doing or the outcome or like management of my condition is always lost on people, which really confuses me. And so thank you for actually doing that and thinking about that. That's a good point. What about medications and taking people off medications or using them more strategically?
Yeah, I think that's the point. We're using them more strategically. And if you look at, our medicine, our system is broken. We're going bankrupt. We could be spending this money on better things than amputations and dialysis. Trust me on that. So I think that's part of it. Is when you look at the coronary calcium score, it's a cash pay thing. It's about $100. So for me to get a $100 test to say what's my risk of coronary disease, and I could change my lifestyle based on that, or change my medications or diet, I think that's money well spent when you think about how much a statin drug is going to cost you for the next 40 years, right? And how much it's going to cost the system. So what I'm finding medically, I've had 11 people come off insulin in the last 10 months. And 12 years before that, I had 0 come off insulin by diet. So it tells me, hey, this is working. On a ketogenic, low carb, there's so much spectrum on this. Some people are doing intermittent fasting. Some people are shortening their eating window, just resting their pancreas a little bit. So I've been surprised at how many people we could start reducing meds. Last week I had a lady, we took her off 4 meds on one day. And so those are exciting things. And patients love you when that happens, right? Because they're seeing that their costs are going down. But what they don't see is they're not going to be paying for dialysis. They're not going to get neuropathy. They're not going to get all these disease processes because they're changing their lifestyle. I'm not changing their lifestyle. They're doing it. So that's what I'm seeing is exciting. I'm using a lot less insulin. I haven't started an insulin on anyone at least in 6 months.
Amazing.
A new start of insulin. Because I say, look, here's our options. Sometimes you need it. If your pancreas is gone and you're going to need insulin to manage things for a while. But if we do it for a few days and get your body to make insulin again, you don't need exogenous insulin. You don't need those injections and shaking your finger every 3 times a day type thing. So I'm seeing that statin drugs, that is still, the problem we run into in medicine is there's a standard of care. And if you're outside the standard of care, you put yourself at risk. So if I take someone off a statin drug and they have a heart attack, which if you're diabetic, you have an 80% chance of having a heart attack if you look at the data, it's going to be a problem, right? You're going to be in a malpractice case and it's going to be a nightmare. You're going to have to defend yourself. And so, I think until we get enough data, it's a really slippery slope of stopping meds. But, if I get a coronary calcium score at 0 and I have all this data and, talk to a cardiologist, I have a cardiologist that I actually trained with. We went separate paths for 12 years named Brett Shearer. And he has an excellent podcast called Boundless Health. He's doing the same thing. He's looking at the same data and he's saying the same thing. So when we have cardiologists and respected docs and people along those lines saying, hey guys, we're going down the wrong path here, then we change the standard of care. And that's why we're doing what we're doing, because at some point we're going to fight and change the standard of care to say, hey, we don't throw everyone on a statin drug thinking that dropping it 1% is going to save everyone's life, right? So that's the problem, is there's such a stigma out there with statin drugs, meaning if you stop them and someone has an event, the head of the American Heart Association had a heart attack at 52 years of age following the standard of care. So he has significant family history. He was at major risk, no doubt about it. It's not because he was on a statin drug. But the point is, when it happened to him, the American Heart Association came out and said, well, this just shows it can happen to anyone. We have to be more aggressive in what we're doing. Instead of saying, you know what, sometimes it just happens and, maybe the standard of care is wrong. And maybe if he wasn't eating, you're seeing stuff now where the American Heart Association is giving Lucky Charms and Cocoa Krispies and all these high sugar, terrible things for you. Their seal of approval saying this is heart healthy.
It's insane.
Like, really? It's insane. It's absolutely insane, especially with the data we're seeing with elevated insulin, diabetes, and all these problems. How can you possibly justify that? So those are the kind of things we're looking at where we have to change the standard of care and the thinking of, okay, if it's low fat but high carb, it's good for you.
Yeah. I mean, you guys are doing fantastic work. One of the things I want to touch on is just something that you mentioned before, is that approaching all this stuff from a more holistic standpoint, looking at lifestyle, movement, nutrition, everything. I like to dig into all my guests and ask them kind of how they approach each phase of this. So we're going to go through nutrition, movement, sleep, and stress management. And so we'll just start with Rachel and then move on to you, Doc, after that. But Rachel, just hit us with what you eat on a day-to-day basis and how you approach your nutrition.
Okay. So I follow, obviously, a low-carb ketogenic diet. And I focus more on just, whole food sources. I'm obsessed with avocados. So I have at least, an avocado or one of the mini ones a day. And just, eggs and meat and vegetables. It's kind of, I like to keep it simple, but I also like to do a little bit of, recipe testing. And my main thing is I really want to encourage, people to look at this as a lifestyle. And sometimes with a lot of people, if you remove the sweets and remove the higher carb things and the pizza and all that stuff, no one's gonna bite. So if you can show people that you can make, low carb keto friendly options, take a pizza and make it low carb, use almond flour, a little bit of cheese, stuff like that. And you can kind of teach them those things, you'll have a much better rate of people, adopting this as a lifestyle rather than a diet. So that's what I like to do. Just experimenting and taking, I think that you can take any dish that's high carb or any food and make it low carb if you try and make it actually, taste good. So that's nutrition wise. Movement wise, right now I'm actually starting a new strength program. I joined a CrossFit gym here in San Diego, but I'm taking a step back from doing WODs, and I'm just focusing more on building up more strength, and then just doing a little bit of high intensity work, a few days a week, and then a little bit of cycling. I'm looking to do another triathlon, so I'm trying to get back into that. And yeah, I get bored really easily, so I like to just do things that I enjoy doing. And that kind of goes into the stress part of it. My stress release during the day is, going out and getting exercise and, doing my workout. That's like my, release from everything else. So that's really how I manage stress, is just making sure that I'm doing an exercise or doing a workout or something that I enjoy. And yes, it's going to be a little bit hard, but I like the feeling afterwards. And sleep. I haven't had much issues with sleep. Actually, it's funny, when I was living in West Palm Beach, I was, working out at night because my job, that's just kind of how it worked out. I had to be at work pretty early, and I got out at 5, and I just found myself, having the rest of the night not doing anything. So I kind of switched my workouts over to the nighttime for about a year. And looking back on it, my sleep back then, wasn't very great. And now when I moved to San Diego, I started working out in the morning again, which is what I prefer. And I haven't had really any issues with sleep. So, I'm not sure if it was because I was working out at night, or because I was, maybe in a job that I wasn't really enjoying, those kind of factors. So I think, they just all tie into each other.
Yeah, I think the routine around winding down for sleep is just different for everybody. I can't work out before I go to bed either. If I work out at night, I'm up until midnight, 1 a.m. easily every time.
Yeah.
So that's me. Yeah. Awesome. Super applicable. Doc, what about you?
Yeah, I'm like Rachel. I believe in a whole food diet. The more I've looked at it, I'm trying to do more grass-fed beef and a lot of vegetables, more so than in the past. And unlike Rachel, I don't have a great figure like her, so I have to do intermittent fasting sometimes. She's in really good shape and she's an athlete, so I have a sedentary job, and so I've looked at the data, and for me, trying to be insulin sensitive, intermittent fasting works very well. So if I'm super busy on Mondays, generally I don't even eat on Monday until I come home and have dinner with my wife, maybe. Or, if I'm working late, I'll start on Tuesday at lunch, depending on the week. And I listen to my body. If I'm really hungry, then I'll have macadamia nuts or something around that I can have in an emergency if I'm just feeling whatever that day. I do some prolonged fasting here and there, 3 to 5 days, depending on the week and what I have going socially and all that. So, but generally I'm eating 2 meals a day, doing a whole food diet, cutting out processed foods almost exclusively. My general rule is I have a buddy who owns an Italian restaurant, so I'll have bread at his place when I go there once a month. But the rest of the time, I'm not eating bread during the week or at all. So that's diet-wise. Movement-wise, I love to do different things. Whatever, I'm very social, and I don't have a lot of free time. So I'll go hiking with, buddies in the mountains, or I'll go for a mountain bike ride. I'm getting into road biking now, so Rachel and I may do that a couple of times. She can teach me. So I do work out generally 4 to 5 days a week, and I'm doing more interval training type stuff right now. Where I push it hard and then relax. I do kickboxing as my go-to. Generally, I enjoy that. Sleep has not really been an issue for me, other than being a doctor and being sleep deprived chronically. And so I generally like to work out in the morning. I'm kind of spacing it out a little bit more so I get my sleep, because I get up at 4 a.m. and do morning rounds and catch up on paperwork and all that kind of stuff. So I think it's the management of stress and sleep is really tough for docs. And I think nowadays what I'm doing starting this year actually is taking Fridays off and doing consulting with nutritionists in town like Rachel from a medical perspective, because the problem is a lot of people, their doctors say, no, not getting insulin. I don't care. I'm not ordering it. Or it could benefit the patient, but the doctor just doesn't understand that. So we're seeing that more and more. And I see my role now is consulting with other docs and spending time doing that. And that actually lowers my stress level, because I really enjoy it. I enjoy sitting down and just explaining things and talking to people, and hopefully knowing that I'm going to be able to make some kind of impact here in San Diego at least, and hopefully nationwide as more and more people get it. Because I think our goal, and it's kind of a joke, but our goal is to work ourselves out of a job to some degree. Because if Rachel does her job, it should be like raising kids where the patient gets it and then they move on. And then when the next person comes in, you help them and then they move on, instead of making them dependent on you their entire life. And I think in medicine, I'm seeing the same thing. And it's a huge stress relief to have patients come in and say, Doc, I'm off 3. Oh, look at my weight. Look how much I lost. Look at this. Look at that. And they're super excited, and they're excited to see me now, right? They can't wait to see me, because they're like, hey, guess what? I'm down here 10 pounds and my sugars are better. Look at my sugar logs. And they're, instead of trying to hide behind something, they're like throwing it out there, smirking, saying, look at this, look what I did, type thing. And so that's a huge stress relief. And I think, was there one more thing we're supposed to address?
No,
Sleep,
I think,
stress.
Yeah, you nailed it.
Memory might be a problem, but other than that, doing all right.
Yeah, crushing it.
No, but yeah, it's fun. We're having a great time here, and just having people like Rachel with integrity, and Jeff Cotterman and the rest of the group down here in San Diego. We've been so fortunate, and we enjoy each other, and we go hiking together, we spend time together, work out together, and try to have a healthy lifestyle.
Yeah, easy place to do it. Mm-hmm. All right, guys. Well, appreciate you being on the show. If you want to, Rachel, just let us know where you can find you after people tune out here.
Yeah, you can go to my website. It's www.killinitketo.com.
With no G, correct?
No G, yeah. Just Killin. Same on Instagram, Facebook, Killin' It Keto.
Awesome. And you, Doc?
lowcarbmd.com.
Perfect. Any social media? Too busy for that.
No, I do Twitter.
Yeah, you do.
Twitter I do a lot, because I keep in touch with all the docs that way. It's really helpful. Tim Noakes and all these guys are really they're putting a lot of their studies on there. So it's I think it's at Brian Lenzkes.
Okay, well, we'll do some research and put the accurate one in the show notes if it's different. Otherwise, thanks guys for doing such great work. I'll make sure to look you up when I'm in San Diego next time, and we'll chat later. Okay.
Sounds like a plan. Hey, thanks for having us on. Really appreciate it.
Yeah, thank you.
Keep up the good work.
All right, thanks guys. All right, everyone. Thanks for listening to another episode of the Keto Answers podcast. I hope you enjoyed it, but even if you didn't, I would love a review. Just go over to iTunes, wherever you listen to your podcasts, and pop in a review so we can get found by more people, get better guests, and have the information that you need. So please go to iTunes, wherever you listen to your podcasts, and leave us a review. And if you're new to keto, head on over to perfectketo.com/podcast and enter your email for all our top tips and guides on getting started with the ketogenic diet.